Here's Lesson B for EMS 150. In Lesson A, we talked about several types of shock. We're going to work through each of those types over the next few lessons. The first one we're going to deal with is obstructive shock, defined as an obstruction to flow somewhere in the system, how to assess for obstructive shock, and then what emergent immediate interventions we're going to use. So obstructive shock is an obstruction to flow somewhere inside or outside the system, the cardiovascular system. The primary example that we'll spend the most time on in this lesson is a tension pneumothorax. Other examples of obstructive shock would be cardiac tamponade or pulmonary embolus, and we'll address those at the end. So for now, let's talk about and think about what a tension pneumothorax would be. So a tension pneumothorax is a particularly bad version of a simple pneumothorax. A pneumothorax is defined as air outside the lung that's trapped inside the chest cavity in the pleural space. The air is in the pleural space. Normally the pleural space is a potential space, meaning that there is no space. There's a visceral pleura and a parietal pleura. The visceral pleura lines the outside of the lung. The parietal pleura lines the inside of the chest wall. And those two pleura are adhesed together with a little bit of fluid in between the pleura, very much like when you have a glass that has cold stuff in it and it has some condensation that rolls down, and there's then a thin layer of fluid between the glass and the tabletop, and you just can't pull them apart very easily. So the same thing goes on with the pleura. The pleura are stuck together, although not mechanically connected. They are stuck together and stay together only because of that fluid in there. But there's a possibility that should that be disrupted by air occupying that space, then that the lung will collapse and a pneumothorax is the result. You can have a simple pneumo, you can have a spontaneous pneumo that occurs just naturally for some unknown reason, a congenital defect, particularly tall, thin males end up with just suddenly popping a hole in a lung, and then a pneumothorax results from that. Chronic lung patients as well may have a weakened area of lung and maybe a coughing spell or something, and they end up rupturing that lung to the point where you then have a simple pneumothorax that develops. A tension pneumo is a simple pneumothorax that has continued to develop and build and build and build. And so the air bubble that's inside the chest wall, outside the lung, now gets large enough and is under sufficient pressure that it puts pressure on the heart and on the great vessels, and it puts pressure in the area of your chest known as the mediastinum. Mediastinum is a region, it's not a structure. It's in the center of your chest, runs north and south. And in that space, you would find the trachea, you would find the heart, you would find the great vessels, meaning the aorta and the vena cava. And so as the tension builds up in one side of the chest, that pressure starts to push and move the structures in the mediastinum away from that pressured side. And when your heart moves from one side to the other, it doesn't just slide over nicely, it actually torques. And as it torques, it tends to kink the vena cava. Think of the vena cava as a collapsed hose, a collapsed fire hose, perhaps is a good analogy. The aorta tends to have a little more structure, more like a pipe, whereas the vena cava are more like hoses. And so as that heart starts to torque and turn, it kinks the vena cava, and now you have a reduction in blood flow coming back to the heart, reduction in preload, because the return pipe has been kinked. Therefore, you have reduced preload, you're going to have a reduced ability for the heart to pump. It can only pump out what it gets in because the heart's not able to pump out much blood. Now your cardiac output goes down and you go into a shock condition, which continues to escalate until it becomes decompensated shock. That's the point at where you have hypotension. So remember, shock has nothing to do with blood pressure. Determining whether you're in shock or not has nothing to do with blood pressure. The patient will have signs of shock, but then at the point where they have hypotension, where they have lost peripheral pulses, or you're able to measure a blood pressure of, say, in the 80s or below. Now you have decompensated shock. And so the tension pneumo has a pulmonary piece to it. The lung is collapsed, so there's a lot less lung tissue actively providing gas exchange. But it's really more of a cardiovascular problem. It says a pulmonary word in its name, pneumo, but it's really a cardiovascular problem. So the deal is that with that obstructed circulation and that non-ventilated lung, you've got a pretty big problem. You've got an oxygenation problem, you've got a ventilation problem, you've got a circulation problem, and whatever caused that tension pneumo is most likely a traumatic thing in the first place. Yes, it's possible for a spontaneous pneumo to turn into a tension, but really we're talking about some sort of traumatic injury where a rib is broken or a projectile goes through the pleural space, disrupts the pleura. So whatever trauma caused the pneumo in the first place is still going to be there and will tend to exacerbate the whole thing. If this was blunt chest trauma, you've got chest wall injury, which makes it hard to breathe, makes it painful to breathe, so patients tend to hypoventilate when they have a chest wall injury. And then there's going to be bleeding as well. And so a tension pneumo results from, in most cases, traumatic chest injury, and that trauma causes additional complications besides the loss of the ventilated lung, the non-ventilated lung collapsing, and that loss of surface area, as well as a problem with circulation. Now, if this was due to a penetrating wound, then you've got a hole in the chest. So a gunshot, a knife, whatever, pokes a hole in the chest and causes the lung to collapse. And with each breath, a little bit of air is trapped inside the chest wall, and over time that builds up. Doesn't have to be a long time, can be a matter of minutes. And that tension builds up. And so if the problem started with a penetrating trauma to the chest, seal up the hole or holes. A good practice for you to get into is when you see a penetrating wound in one part of the chest, you need to look at all parts of the chest. The front, the back, the sides, all parts of the chest. Maybe that projectile went through. Maybe there's more than one projectile. Seal up all the holes. Seal them up immediately with a gloved hand. The glove provides an occlusive seal, doesn't allow air to go in or air to come back out. And then replace that gloved hand as soon as possible with a legitimate chest seal. There's commercial chest seals available. You can make a chest seal out of something occlusive, some plastic bag that the oxygen mask came in, or a plastic wrapper that came on a dressing, or an AED pad, or any of a number of things you can come up with. It's occlusive if air won't go through it. So a piece of 4x4 gauze is not occlusive. Air will go through that. So we want to seal it immediately with your hand, replace that with an occlusive seal. Commercial chest seal is our pick, and that will seal up the initial problem. That may also allow that tension pneumo to develop, but we do not want to have a hole communicating to the outside air, where we have air coming in through the mouth as well as air coming in through the hole in the chest. So seal the chest wound is the very first thing, and then watch for the development of a tension pneumo. You would know that there's a tension pneumo when you have loss of lung sounds on one side and hypotension measured by blood pressure being too low or simply the loss of peripheral pulses. How do you deal with that obstructive shock? Well, we place a vent hole in the chest. Now, if they've already got a hole in the chest from a gunshot or stab and you sealed it up, unseal it. Burp the seal. See if you can get some air to escape from that, to relieve some of that pressure. But nobody said that the only way to get a tension pneumo was to have a penetrating wound to the chest. Think of the guy that's driving down the road in his car, comes to a sudden stop, chest hits the steering wheel, ribs break. He doesn't have a hole in his chest, he has a hole in his lung caused by a broken rib. So in that case, you don't have a hole to unseal when the tension develops, and you have to make your own vent hole in the chest. to relieve that pressure that's built up, that's causing a reduced preload, which is leading to reduced cardiac output, which is leading to reduced blood pressure. So when do you deal with this? Well, as soon as you assess it, as soon as you reasonably suspect it. You don't have to be 100% right. When you have loss of lung sounds and loss of perfusion, it's time to deal with a tension pneumo. Not when you have loss of lung sounds or loss of perfusion. You have to have them both there, and that's the standard we're using at this point, is when you have loss of lung sounds and loss of perfusion, that's when you treat. That's a very key concept. And so again, when I say key concept, you should expect to hear about that in lab. You should expect that to be on the readiness check. So the other time that you may notice this is during a cardiac arrest or a patient that you are ventilating. And when you're ventilating a patient who has excessive pressure inside their chest cavity, outside their lung, it becomes hard to squeeze the bag. Not suddenly, gradually. And it may sneak up on you. And then think about, who do you have doing bag valve mask ventilation? Is it your partner? Is it you? Is it always a paramedic? Or is it maybe someone with less experience and less training? And so you're still responsible as the paramedic, even though you've turned over your bag mask ventilation to an EMR or an EMT, and you need to coach them and then occasionally reach over and check for yourself. But decreased lung compliance, situation where it becomes harder to bag, is a very early sign and a very reliable sign that a tension pneumo has developed. A medical cardiac arrest can have a tension pneumo involved. Chest compressions break ribs. Broken ribs poke holes in lungs. Positive pressure ventilation helps for that tension pneumo to develop. And so while it's necessary to ventilate, we have to be aware of that sort of thing. And anytime you're doing positive pressure ventilation, you should be constantly monitoring that patient for developing a tension pneumothorax. And then on traumatic cardiac arrest, we just empirically treat both sides of the chest. And so what we mean there is that when your patient is in cardiac arrest due to a traumatic mechanism, it is perfectly appropriate and expected that you will needle chest decompress on both sides to eliminate, as best we can at this point, a tension pneumo from even developing. And a tension pneumo is a likely cause of traumatic cardiac arrest. And so it just seems reasonable to go ahead and needle both sides. How do you do that? Well, you need something large, you need something long. There are large and long 14-gauge IV catheter style devices. The ARS device is what we use in class. It could also be something as impressive as a 10-gauge IV catheter, or there are numerous other devices. It seems like about every fifth paramedic in the world has invented a way to needle chests. And so you need something large and you need something long. You need something in the 3-inch long range or longer, and you need something in the 14-gauge bore or larger, 14, 12, 10, something like that. If this were done in the hospital, they'd put a chest tube in, and the chest tube is a heck of a lot bigger than any IV catheter style device that we're talking about. Another excellent way, probably the best way, and I think our program would support this as what should be happening in the field, is something called a finger thoracostomy. Not very many places are doing that, but we know of a couple services who are. In that case, you cut with a scalpel a finger-sized hole in the chest wall. And the advantage there is that once you've made the cut and you stick your finger in, you can feel the pleura. You can be sure that you're through all the tissue and you are into the chest cavity. And it's a big hole. And in this case, we would like a big hole that isn't going to be obstructed with clots and chunks and dirt and pieces of shirt and whatever else is in the way. We would like there to be a large hole. In the emergency room, a chest tube would be placed to a water seal vacuum, and so that is clearly the best thing. But there's a lot of setup to that, and you got to hassle with the water seal device, and it's just kind of a pain. So the field version of relieve version of relieving a tension pneumo has traditionally involved large, long IV catheters. And hopefully, like I say, we're going to transition as time goes on to a finger thoracostomy. The other thing I really want to emphasize, and I mentioned it a second ago, but didn't really stop and make a big point. Positive pressure ventilation is going to worsen the problem. Here's the real situation I'm driving at. A flail chest is 2 or more consecutive ribs that are next to each other, 2 or more broken in 2 or more places, such that you end up with a segment of chest wall between the fractures that is free floating. And in the deep dark past, we used to use a bulky dressing, which never worked. And now the accepted practice is that positive pressure ventilation is the way to stabilize that flail. Because with negative pressure ventilation, our normal people breathing on their own pattern of breathing is negative pressure. And so when they take in a breath, they create a negative pressure, and that unsupported chest wall segment will cave in. And when they exhale, their chest wall goes in, but the unsupported one follows the pressure. The pressure is higher and it goes out. And so you have a piece of chest wall that's moving paradoxically in the opposite direction of the rest of the chest because we're doing negative pressure breathing. If we'll switch to positive pressure breathing, then all the chest wall will move in the same direction. So that's great. That treats the flail, but it now adds pressure to the ventilation, which will rapidly increase the development of a tension pneumo. So ventilate your patient when you need to, but realize that there is a side effect, an unintended but not surprising consequence of doing a treatment, a side effect, and that side effect to positive pressure ventilation is increasing a simple pneumothorax into a tension. Now, nobody said that just because you placed an IV catheter type device or a chest tube in the patient's chest and relieved the tension pneumo, that it won't build back up again. The IV style devices are pretty good for relieving the initial tension pneumo, but not very good about staying open. And they can become kinked, they can become clogged up, they can clot off, and you just really end up, in many cases, unless your transport time is really, really short, you end up treating that tension pneumo. You end up with more than one needle in the chest on the same side to retreat a redeveloping tension pneumo. So these patients are usually a hurry up and go kind of thing. The general plan with trauma care is to go fast and get as much done as you can, handle the basics. And relieving that tension pneumo is important. But remember, now you're trying to reassess lung sounds, and reassessing lung sounds on the move in the back of a moving ambulance is not easy. And so there's other causes of hypotension that may also be involved besides obstructive shock. Remember, our patients can have more than one type of shock. They could be low on volume. There could have been whatever the projectile was that went through the chest, also went through the spine. Now you have a neurogenic shock on top of it. It could be that there's a cardiogenic shock involved. Maybe you have direct damage to the heart. And so none of this is simple. And a constant reassessment for a tension pneumo is really, really important. Now here's down to the nitty-gritty on tension pneumos. In the old days, we were taught that once we placed a needle in the chest, there would be a rush of air. But when you ask around, people that have done this a lot have rarely, if ever, heard the rush of air. So if you hear a rush of air, or maybe a spewing, a spraying of fluid that comes from the chest needle when you place it, that's great, good for you. But just because you don't get the rush of air or didn't see a spray doesn't mean you're not in. So the rush of air complication to us means beware that almost nobody hears that. Either it isn't there, or it's too quiet to hear, or it's really loud where we're doing this, or all three. And so that's one thing. Then there's the, well, I needled his chest, but he didn't get better complication. And that's not uncommon. Remember, they can have more than one kind of shock. Maybe you did get the tension pneumo relieved, but you have been unable to deal with the massive amount of blood loss that occurred, or the neurogenic shock that he's in, or the cardiogenic shock that he's in. So just because you needled the chest doesn't mean that the patient gets better overall. Now, it's likely that if you needled the chest and you had difficult ventilation prior to needling and decompressing the chest, if it was hard to bag him before and you fixed it and it got easier to bag, that should make sense. That should be the case, but the overall patient may not get a whole lot better. Then there's the other thing, and this is the hard one. I'm not sure it's still in there, complication, where you needle the chest, but you remember from class and you've heard from other people that frequently those IV-style devices will kink off, clot off, clamp up, and you're just not sure if it's still there. And so just because you have the hub of an IV catheter sticking out of a guy's chest doesn't mean that the tip of that catheter is still in the pleural space. And so it's a judgment call, and it requires thinking, and it requires action. And so in this particular case, we would rather see you put 4 or 5 or 6 needles in the chest and not need any of them than to hold off on placing any one. Don't be afraid to do this. There isn't time to analyze this to the nth degree. Once they have no lung sounds and no blood pressure, you've got to do something. Again, the rush of air, sometimes you'll hear it, most of the time you won't, and it's not going to keep happening continuously. So you'll relieve that pressure, and there should be a rush of air. Maybe you can perceive it, maybe you can't, but it's not going to be continuously. You won't be able to stick your finger down there over the hub of the catheter and feel air coming out of there all the time. Again, I said maybe the guy doesn't get better. Well, what could that be? Maybe it wasn't really a tension. Maybe it was a massive pulmonary contusion or a large pneumothorax. Who knows? Or maybe you didn't actually get in through the chest wall. There's a lot of judgment involved here. And this is where we really like that finger thoracostomy as an option, because you absolutely know if you're in. That is positive confirmation of placement when you can stick your finger in the hole and feel parietal pleura and feel that you're in the chest cavity. And then again, continuing to repeat some of the stuff I was saying earlier, I kind of, on the summary slide, I kind of went into each one of them instead of waiting for this. But again, trying to feel for air escaping is not going to work. If you don't think it's in, reasonably don't think it's in, put another one in and move on. Then last thing, other obstructions. So we said this is an obstructive shock lesson, and we're talking about tension pneumothorax as the most common example, but it's also about the only treatable example. 2 other examples of obstructive shock causes would be a cardiac tamponade and a pulmonary embolus. And the punchline's at the bottom. We can't treat either of those in the field. Both of them should get fluid volume, resuscitation, and rapid transport. So saline and diesel fuel is the only thing we can do for these. And I'm not telling you that that's treating them. It's the only thing we can do to try to manage them while we move rapidly to an ER setting where something can be done. So cardiac tamponade, and you can look this up in your books and other resources, but cardiac tamponade is a buildup of fluid in the pericardial sac, the thin but tough and not all that stretchy sac that surrounds the heart. Hopefully in cadaver lab experience, you'll get a chance to touch it and feel it, and you'll be, I think, be impressed by how thin it is, but yet how tough it is. And so as fluid builds up, then there is an obstruction to filling of the heart. So really the obstruction is external to the cardiovascular system. It's in an area surrounding the heart, but it's still an obstruction. It's an obstruction to the heart being able to fill and therefore being able to pump. And yes, in theory, there's descended neck veins, and there's distant heart sounds, and there's a narrowing pulse pressure, and it's just, lots of things that are nice to know and answer a test question on, but appreciating a change in pulse pressure in the field environment is, pretty hard to do. And heart sounds, we can barely hear lung sounds in the field, and most of us don't do heart sounds, so we're not going to know what a normal heart sound is. How are we going to know if one's diminished? And lots of things can cause JVD, and you have to have sufficient blood volume left to even get JVD. So diagnosing tamponade in the field is an iffy thing. If you were to strongly suspect it because your patient's not better and they have chest trauma, and you've needle chest decompressed and they're just not getting better, then maybe that's what it is. But you're already going to be moving rapidly toward a trauma center, and you're already going to be doing fluid volume. But we did want to make the point that fluid volume is about the only thing that's helpful, and it's marginally helpful. So they should get fluid volume to try to increase their preload and try to push against some of that constricting force that's on the heart. Pulmonary embolus, I think, is also an important thing for you to understand. Pulmonary embolus is a blood clot in the pulmonary artery or arteries. It's on the arterial side in the pulmonary circulation. It is obstructing flow out of the right ventricle. The right ventricle is a high volume but low pressure pump. The right ventricle cannot generate the same amount of squeezing force that the left ventricle does. It's just not built that way. And so in your systemic circulation, you're used to blood pressures of 120/80, but in the pulmonary circulation, it's like 20/8. And so that right ventricle is not a high pressure pump. It's high volume, but it's not high pressure pump, and it cannot deal with an obstruction such as a huge blood clot stuck in a pulmonary artery or in pulmonary arterioles. And that right ventricle is going to then be struggling against that obstruction, and it turns into an obstructive shock. Okay, so in Lab B, we're going to do some lung sound work, and we're going to work on chest seals, and we're going to talk about needle chest decompression for tension pneumo. And so Lab B is a chance to work on a couple of techniques, a couple of skills, so to speak, as well as to deal with assessment of these very, very sick patients. Obstructive shock patients don't stick around very long. So that's it, and we'll see you in Lab B.